Okay. Okay, thank you, Dan.
Go ahead, Lauren.
Okay, Lauren, go ahead. Thank you.
Okay, thanks. How's my voice? Can everybody hear me? Am I loud enough? Okay. So I'd say welcome to everyone and thanks for attending the program Ask the Audiologist. The purpose of this program, which we have offered in the past, is to address questions that we might have about our hearing. Some examples are, things like, can earbuds cause hearing loss? How do I know if I have a hearing loss? What do I do about ringing in my ears? And things like that. Basically, any question related to hearing is something that we hope you ask, because this is the time to do it. To address your questions, I'd like to introduce two local audiologists that many of us know very well, Dr. Carly Alecia and Dr. Peter Hart. I want to thank them both for generously taking time out of their schedules to address our concerns, our questions, and our thoughts about hearing. First, I want to say to Carly, I apologize in the invitations that went out. Your name was spelled incorrectly. It should be EA at the end, not IA. So we knew that, but we fat fingered the keys. So apologies. Dr. Carly Alecia joined Rochester Hearing and Speech, the Rochester Hearing and Speech Center in 2021. Her clinical and research interests include oral rehabilitation for adults, public health issues related to audiology, hearing screening, and expanding access to hearing healthcare for underserved populations. She has researched adults' motivation to seek help for their hearing problems, new methods for teaching new hearing aid users to use and care for their hearing aids, and parents and caregivers' abilities to care for their children's hearing aids. Her daughter is hard of hearing, and she supports other parents in celebrating their children's abilities and their accomplishments. Dr. Peter Hart earned degrees from SUNY Geneseo and the University of Akron. He interned for a year at the VA Medical Center in Canandaigua, and he has been an audiologist with the family firm Hart Hearing and Balance Centers since 2012. So with those introductions, I think we can get started. I just wanted to let people know that there are three ways to indicate if you'd like to ask a question, and we hope you do ask. Is one, you can raise your hand to be recognized, just raise it. And another way is to click on the reactions button on the bottom of the screen. If you don't see any buttons down there, just move your mouse to the bottom and I think they will pop up and you'll see them. You click on reactions and then raise hand. And you can also click on the chat box near the bottom of your screen, and you'll see a panel open up on the left or right side of your screen. You just type a question under the text that says type message here. And also, please keep your microphone on mute unless you're asking a question. The reason being is that the mics really pick up everything in the background. So we'll hear paper shuffling, and if you're having a side conversation, we'll hear that as well. So you can mute or unmute using the button on the lower left side of your screen, which looks like a little microphone. And you can also, if you are muted and you just want to say something quick, you can hold down the space bar while you're talking. That works on many systems. Sue is going to moderate the meeting. She'll be watching for raised hands and chat messages, and we'll call on people by their screen name. So I'll get things started with a question for Carly and Pete, and then I'll turn it over to Sue. And my question for you both is, what got you interested in audiology? Why did you go into this profession? Start with Carly.
Sure. So
I had sort of a curvy road to audiology, but I was always very interested in deafness. And I was always interested in sign language. I took sign language in high school as a second language. And I was always taught by deaf instructors who, you know, when they found out that I was interested in working with deaf people, encouraged me to go into audiology or speech therapy, because they said that we needed more audiologists or speech therapists who understood deaf community and understood, you know, deaf perspectives. And so I took their advice. I thought I wanted to be a speech therapist. And after really just a few months of classes, I discovered that really what I was interested in was hearing. I didn't think speech therapy was for me. And at the same time that, you know, I was thinking about, did I really want to be a speech therapist? I was having some unique auditory symptoms. I had tinnitus in my left ear and like weird feelings of pressure or fullness in my left ear. And so I saw a lot of audiologists and ended up being diagnosed with an acoustic neuroma, or a vestibular schwannoma, it's sometimes called, on the left auditory, well, the left vestibular nerve technically, but our auditory and vestibular nerve, you know, are two branches of the same piece. So I started going to the audiologist a lot for hearing tests and trying to determine what the best course of action would be for, you know, my own auditory problem. And after spending so much time in the audiologist's office, I discovered that, you know, that was really where my passion was. So, you know, my acoustic neuroma was treated years ago. You know, it's not a problem for me now. I do still have some tinnitus, so I can always sympathize with my patients who come in and are bothered by tinnitus. But that was really my path to audiology, sort of an unexpected journey.
Thank you. Peter?
Sure. And you know, my path started just growing up with my dad. You know, he's been an audiologist for 40 plus years. So being exposed to that, seeing how much he loved his job, seeing how rewarding it was, you know, it was always in the back of my mind that it was an option. You know, I want to love my job like he loves his job. That being said, going into undergrad at Geneseo, I was not going in for speech or hearing. So I started out as a more of a finance or an accounting major, and pretty quickly realized it was not for me. So, you know, early sophomore year, I, you know, sat down with my parents and said, I have to pivot. I don't know what I'm going to pivot to. And my dad said, why don't you just take some audiology courses? And, you know, I've always been interested in it. I've always asked questions. And, you know, pretty soon after I started taking the audiology courses, I realized, you know, this is the path that I want to take. The other side of it, you know, I've always loved the technology side of things, you know, whatever it is, I've loved the technology side of things. And that always intrigued me, you know, just talking to him about that, you know, when, you know, he was in the analog to digital transition. And I remember, you know, in the back of my mind, just being like, wow, this, you know, is incredible. So that side of things has always been of interest. And, you know, once I started taking the courses and saying, yeah, this is a good fit for me, I committed 100%.
Those are great responses, Lauren. I'm glad you asked that question. Okay, now there must be somebody who has another question. So if you're gonna, okay, Eric, you raised your hand. Please unmute yourself and ask the question.
Yeah, hi. I'm aware of the forthcoming flood of over-the-counter devices, and I'm expecting a lot of people to ask me for direction on that because they know I'm deaf in one ear and can't hear out of the other. But what would you advise that we tell people like that, and what is your strategy given that you're under more regulations than the other purveyors?
Okay, Peter, why don't we have you respond to that first?
Yep.
And then we'll see
Yeah.
if Kelly has any additional.
So when you use the term flood, I think you're 100% accurate. You know, it's coming. Obviously, we know it's coming. You know, I personally think it's delayed in coming. You know, this has been something that, you know, has needed to be regulated, needed to be, you know, available to patients for years. You know, the regulations, the specific regulations aren't out yet. So it's sort of tough to predict, you know, what they're going to look like once things are finalized. But, you know, like I see people every day, you know, they're having difficulties. They have, you know, measurable hearing loss, but they're not necessarily a candidate for a traditional hearing aid, you know, at this point. But right now we really have nothing to offer except counseling. You know, so I think that, you know, it's too soon to really see what it's going to look like because, you know, all the licensure laws and, you know, just the specific FDA regulations on what these products will look like. But, you know, I believe right now it's mild to moderate hearing loss. It's something that, you know, certainly is going to be beneficial to many, many people. It's just once they finally make, you know, hit the ground running. And I know there's a few products out now, like Bose has a product out, and I've actually encouraged a couple patients to try it. I haven't heard back if they have or not, because again, I saw them and I said, you know, a traditional hearing aid for the expense, I don't think you'll notice the benefit. But try this. It's $800 for a set of them. I believe they have a 90-day full refund trial period. So there's really nothing to lose in that case.
Well, that's a good answer. I like that. And I like your acceptance of that too. Dr. Carly, anything you want to add to that?
Sure. I think I would just add a few things. You know, one thing that I often talk about with people who ask me about, you know, these devices, which, you know, will soon be available. You know, one thing I like to emphasize with people that, you know, Dr. Hart brought up is that, you know, these devices are going to be approved for use for people who have mild to moderate hearing loss. And we know from research studies that patients are actually really not very good at estimating how much hearing loss they have. And so I always tell people that even if you know, think you're going to go out and buy an over-the-counter device, you should get a hearing test first, because you want to know if that device is even going to help you. You know, I think that a good number of these devices will actually be quite good devices. For example, the Bose product, you know, Bose makes very good audio products. I think that their device will probably work well, but it will work well for the people that it is appropriate for. And so, you know, people who say, oh yeah, I think my hearing loss is mild and this will work well for me, and go out and spend a lot of money on it, may not actually be getting the benefit that they need because it may not be the right type of device for them. So I think encouraging a hearing test, you know, or, you know, even a hearing screening with something like the device that I know HLAA has, that has been talked about, you know, before, I think is a really good first step. And I think it's good to encourage others, you know, who ask you about it, to start there.
Great, what good answers. Okay, now who else has a question with all these people, about 25 people? Who else has a question? Laura Arne, what's your question? And do you have a specific person you would like to address this to?
No, I think each will have a different perspective, perhaps. My question is, how can I better communicate with somebody that's got a voice that is difficult to hear? The first thing that comes to mind is it looks like this Bluetooth thing might work, but then I have hearing aids that don't allow for Bluetooth or something like that. I might be in a restaurant and would like to talk to people, but how do I get closer to them? Or in the car where road noise or even the heater sounds loud. So it's a general question, but those were some of the examples that I would like to deal with.
Okay, Peter, would you like to
so
first?
Sure. So, you know, you're right. The whole transition of hearing aids into this wireless realm has really opened up a lot of possibilities for some of those exact situations that you mentioned, because we know that the effectiveness of hearing aids in terms of communication really sort of drops off the cliff once you get beyond, 10 or 12 feet. The other side of that, like you mentioned in the car, in the car, presumably someone is watching the road. So that conversation is not going to be face to face. And road noise is, we don't really think of it being loud, but it is. We've just, it's loud, it's distracting, it's constant. It's lower frequency, so it really drowns out those highs. So the Bluetooth technology is a huge, or the wireless technology, I should say, is a huge benefit because, obviously, instead of the sound traveling 15 feet or, if someone's not looking at you, it's almost like they're in your ears. And stereo, you're going to get in both ears, presumably if you're wearing binaural hearing aids. The non-Bluetooth hearing aids, Bluetooth has been around for a while to a certain extent. So previously devices, you would need a middleman like a Comm Pilot or a little pendant you would wear around your neck. And that would, enable a lot of hearing aids to be Bluetooth. But, pre-Bluetooth hearing aids, it's sort of a challenge in those situations because there's not really a direct way to stream through the hearing aids. If you use a portable loop, let's say, if you have a portable loop, T-coils have been around in hearing aids for years, but, that's limited as well. That can allow you to connect to your television at home, but you're not going to be, lugging it around to restaurants, most likely.
Okay, thank you. Dr. Carly, any take on your part?
So I think Dr. Hart did a really good job of covering, the technology side of that question. So I'll just talk a little bit as well about communication strategies, which don't know that this was quite your question. I think Dr. Hart probably better addressed your question, but I'm wondering if perhaps for you or others that sort of led to the follow-up question of, what about when even with these additional accessories or these additional pieces of technology, it's still challenging to hear certain people, because probably most of you, have that friend or that family member whose voice is, for whatever reason, really challenging for you to hear, no matter, what technology you're using. And so that's when the use of, communication strategies and self-advocacy can come into play. And self-advocacy can be really hard because it's, hard and sometimes uncomfortable for us to say to another person, I can't hear you and I need you to do something differently in order to help us communicate. But I always remind people that, communication is a two-way street. It requires effort from both people. And sometimes it requires, people to do things differently than maybe their default. And so it is important to recognize that even if you have the best technology in the world and all of the accessories, there likely still will be times where you may need to ask someone to try and talk a little bit louder. Or I often encourage people to ask people to try and speak just a little bit slower. So when we slow down just a little bit, we articulate our words better, and that makes it much easier for someone with hearing loss to understand what we're saying. You know, doing everything you can to reduce background noise. So road noise in the car is really challenging, but definitely leave the radio off if you're trying to communicate with someone in the car. You can't do much about the road noise, but you can control, you know, whether there's music on or talk radio on in the background. You know, getting as close as you can to people in situations where you can. So if you can at a restaurant, you know, move closer to the person you're trying to hear, or at a party in a group situation, rather than trying to talk from across the room, moving right next to or across the person. It's also really important to keep in mind, you know, those strategies in addition to the technology pieces.
Okay, I see Barbara has her hand up.
I just.
Barb, you're still muted. Barb, you're still muted.
Okay, sorry.
There you go.
Okay, I'm here. Okay. Well, what I wanted, I don't see my face here, so that's okay.
I do.
Yeah. Okay, I was wondering, I have had hearing aids, White X hearing aids for the last 8 years. And I know at some point I'm going to have to get some new ones. And I have a lot of good things about this hearing aid. I have a loop that Bluetooth enables me to hear on the phone. And I have a music setting, and I have a T-coil setting and a microphone setting and a couple other settings. But anyway, how have things changed? Can you give me any examples of new technology in the last 8 years that I should be expecting in my new hearing aids that I buy? And I want to have music setting because I do use it for the RPO and other places. So,
okay, Dr. Hart, since Dr. Carly just finished, what's your take?
Sure. Yeah. So, you know, as you all know, I'm sure things in you know, the hearing aid industry and technology in general is constantly changing. One of the big changes. So 8 years ago, you would, you know, to enable that Bluetooth technology, you would have to wear almost like a personal induction loop type of system around your neck to sort of activate that technology. You know, pretty much across all manufacturers now, that has been integrated into the hearing aids. So you don't need a middleman. So, you know, that preserves sound quality. You know, when you're passing it through one device to another, you know, naturally there's going to be some degradation of the sound quality. So, you know, in theory, the sound quality should be more natural. And, you know, the T-coil or the hearing loop for those large auditorium types of settings, I still think is the gold standard. I mean, it's incredible how well it works. And for that larger auditorium setting, you know, there's really nothing better. And I know, Barb, do you still have the ALD room set up with like a Roger pen, or I'm sorry, Sue, do you still have the ALD room with like Roger demos?
Well, we do, but it's not, it's our demo center over at Lifespan.
Yeah, okay.
And Dan or Lauren, or do we still have the Roger pen over there?
That's a good question, Sue. My ears normally have the bag, but I know we'll have it nearby if we need it.
Okay. Yeah, and so, you know, the Roger system is, you know, a system that one of the hearing aid manufacturers, Phonak, has been sort of developing over the years. And it uses FM technology, which has been used in classroom settings for many, many years. But, you know, I found that to be an incredibly impressive piece of technology. You know, it's extremely directional. It's adaptive. So, you know, you can put it in the middle of your, you know, table when you go out to dinner, and it's not perfect and nothing is, but, you know, in those difficult types of listening environments, I found that to be a huge benefit to a lot of patients.
Dr. Carly, any additional comment for that?
Sure. So the other thing that stands out to me is something that's now available, not in all hearing aids, but in, many new hearing aids that wasn't as easily available 8 years ago, is rechargeability. So for people who either struggle with changing their hearing aid batteries, or people who just want the convenience of, putting the hearing aids into the charger, usually the charger is integrated into the case for the hearing aids. So it's really no different than putting your hearing aids into the case at night. We have many more rechargeable options now for hearing aids, where the rechargeable battery is just built right into the hearing aid. There's no longer a battery door that even opens. And so that is another newer piece of technology that I think that you'll see when you start looking at new hearing aids.
Okay, thank you. John English, you're next. Please unmute yourself.
Yes. I wondered what either one of you recommend to your patients who have unilateral hearing loss as far as cochlear implants. I've had sudden hearing loss in my right ear since the late 80s. And since that time, I've always worked with the Rochester Hearing and Speech Center. I've had 4 or 5 hearing aids for that ear, which really doesn't do much because the loss is so profound. But never the option in those years has been given to me, to think about the cochlear implant. And I know now, it's opening up a little bit for unilateral. And I just wondered what both of your thoughts were on that situation.
Dr. Curley, since you're at Rochester Hearing and Speech Center, why don't you go first?
Sure. So, I feel like many audiologists, and because this was the case, many audiologists, in the past have thought of cochlear implants as really being for, a very niche population of patients. And as you mentioned, our criteria for who may be a good cochlear implant candidate, is expanding more and more as the years go on. So whereas in the past, someone who had a unilateral hearing loss, would not have been considered a cochlear implant candidate, it's now very possible that many of our patients who, have one ear with no hearing and, one ear with normal hearing or less hearing loss may be candidates. So I always encourage people who, ask me about cochlear implants or have an interest in cochlear implants to pursue a cochlear implant candidacy evaluation. So many people don't recognize that, not that the criteria for cochlear implants are not simple, but the types of hearing tests that we typically perform in a standard hearing evaluation don't give us all of the information that we need to know if someone is going to be a cochlear implant candidate. So there's an additional type of evaluation, usually called a cochlear implant candidacy evaluation, that involves more testing than you would get as part of a standard hearing evaluation to help determine if someone is a cochlear implant candidate or not. So if there is anyone out there who thinks that maybe they might be a candidate, or thinks that they would be open to a cochlear implant if they were a candidate, I think talking to your audiologist about whether a candidacy evaluation might be appropriate for you is a great place to start.
Dr. Hart?
Yeah, no, I think, Carly nailed it there. Is, the criteria for who and who is not a candidate is, it's not getting smaller, it's just expanding. The technology is obviously improving, which is in turn, causing the, the candidacy to expand. And, having that candidacy evaluation is key. Because again, it's not something that we do. It's a lot more, it's a lot more driven to say, hey, is there potential for a CI or whatever it may be to help you in your situation? And then if on paper, yes, you are a candidate, and then you can start talking about, what are the risks? Obviously it's a surgery, so there's going to be risks with any surgery that you have. So what are the risks? Do the potential benefits outweigh the risks? And then also that, there's other options. Let's say the final decision is, okay, I don't think a CI is right at this time. There's other options that have been used to treat sort of single-sided hearing loss. Like I know you can do a bone anchored hearing aid. So, which, is still also a surgery. It's less invasive, but it's using bone conduction to stimulate the healthier ear with a hearing aid that is on the ear with the profound hearing loss. And then there's an even less invasive option, which is a cross, which is essentially looks like two hearing aids, but the cross side is picking up the sound from the ear that has the profound loss and sending it to the healthier ear. But like Carly said, if there's interest in a cochlear implant, step one is get an evaluation at a cochlear implant center to see, may this be worth looking into deeper.
Okay, thank you.
Thank you.
And the next person, I'm so excited to see this next person. Cindy Kellner has served as our chapter president, and then her husband was transferred to Florida. And so now we've lost Cindy to Florida. But maybe we'll get her back someday. So Cindy, welcome back. And what is your question for the audiologist today?
Thank you, Sue. It's always good to see everyone, and I can always count on Rochester having a great meeting, so I appreciate it. My question is kind of different. I recently read a blurb, and I think it may have been Reader's Digest, that indicated that hearing loss can be damaged by certain pain medications. And I mean, it was literally 2 paragraphs. My question to both of you is that something that we should be taking seriously and avoiding certain things when we have surgical procedures or dental procedures where they often give you pain medicine? I had heard of this briefly before, but it sounded like there's been more definitive research lately. Are you aware of anything?
Hey, Dr. Carly, why don't you respond first?
So I'm not sure, I haven't recently seen new information, but that certainly doesn't mean it's not out there. I just haven't come across it. Hearing loss certainly can be caused by certain medications. So, as we all know, every medication is going to have side effects. And in addition to the benefits of every medication, there's always going to be, the potential of some downside. And so it's not necessarily uncommon for hearing loss to be a side effect of a medication. So when hearing loss is caused by a medication, or when a medication can potentially cause hearing loss, we say that medication is ototoxic, meaning it could potentially damage, the auditory system, damage the ear, and hurt our hearing. And so the best advice that I have for people who are concerned that, a medication that their doctor is prescribing may be damaging to your hearing is to talk to your doctor to find out, is this a potential side effect of the medication? To ask questions about whether there is an alternative medication that might have, the same or a similar benefit without that potential side effect. The list of medications that can cause hearing loss is so vast that I couldn't even begin to tell you if there are certain medications that should be, avoided more so than others. And of course, it's always a cost benefit analysis. There are certain medications that, really are needed in order to keep other parts of your body, functioning. And in order to keep you healthy, that, you may have to take the risk of hearing loss. But those are discussions that are worth having with your physician, the doctor who's prescribing the medication, if you have concerns about it.
Thank you.
Okay. Dr. Hart, any addition to that?
Yeah, so again, Carly nailed it in the sense that whenever I'm asked a question like that, it's not even remotely in our scope, certainly, to really give advice on changing medications. We can give information, certainly, but I always encourage to speak with the prescribing physician. Even if you just ask, is there potential that this is going to damage my hearing? The ear is such a sensitive system. There's so many drugs that have A, been proven to be toxic to the ear, or B, maybe toxic to the ear. There might not be enough evidence yet, but it's worth asking your physician, is there risk that this can worsen things? And yeah, it is a cost benefit analysis. It's like chemotherapy, for example. Certain chemo drugs can and very likely will cause damage to the inner ear. But then it's a conversation. Okay, well, sort of choosing the lesser of two evils. What other options are there? So it's definitely a conversation to have with your physician, even beforehand, to say, what am I looking at here in terms of side effects? Is there any potential side effects that may worsen or damage my hearing?
Aren't there some that are reversible that can damage your hearing, but some are reversible and some are not?
Yeah, I mean, like some medications, like ibuprofen, for example, or Advil, high doses of that can be damaging to the ear, often cause tinnitus, and often if you stop taking them, that the ear can sort of recover. There's some that are like I mentioned, chemotherapy, or heavy doses of antibiotics can so potent that the ear really can't recover. But yeah, I mean, the ear can recover.
Yeah.
Thanks.
Okay. Does that answer your question, Cindy?
Yes, it does. Thank you. Very good advice.
Yes, good. Okay, Eric. And just as Eric has already asked a question, is there anyone else who has not asked a question yet? Okay, well, we'll go to Eric, and then I'm sure some of the other ones, and we haven't seen many of you or some of you in a while, so it's so good to see all of you. So Eric, what's your question?
Yeah, thanks, Sue. I have a tremendously great set of hearing aids, but I still have difficulty in some situations. And my audiologist advises that it's a processing issue, not an auditory issue. So it's in my brain. I suppose that's age related, but is there anything that can be done about that?
Oh, which one of our two audiologists want to take that on?
I can give it a shot first.
Okay, go ahead.
So,
thank you.
Even the best of the best hearing aids, the newest of the new, unfortunately, they're no replacement for our ears. The ear is an incredibly impressive system, and the best hearing aids just can't replace it. So that doesn't mean that there may not be something that can improve it. So how long ago was your last hearing test, roughly?
About 90 days ago.
Oh, so pretty recent. Okay. Yeah. So my first recommendation would have been get an updated hearing test. If it had been a year or 2 years, get an updated hearing test, see if the loss has changed. And if so, sort of take the path of least resistance and reprogram the hearing aids to see if that helps in those situations. We do process with our brain, we hear with our brain. So the ears are a way in, certainly, but the brain is what's doing really all the heavy lifting. And, just like everything else, as time goes on, that process does, become less efficient. And it's sort of a filtering process. So like in a restaurant, you were, back in when I was 20, maybe I could, ignore all the other speech noise and really just pinpoint the one person across the table from me. But that does become less efficient at sort of separating everything else and just isolating one signal. There's certain technologies, like we mentioned, the Bluetooth and the wireless technology that can obviously help, but the hearing aids, at least at this point, they're still aids. They're going to help. They should help significantly, but that doesn't mean that, there still won't be certain situations, certain environments that can still be incredibly challenging.
Okay, Dr. Carly, anything you could add to that?
I think the only other thing that I would add that, is something that I often talk about with patients is, one of the tests that most audiologists perform as part of a standard hearing test. So probably any of you who have had hearing tests have done this test. Tests are word recognition or our word understanding ability. And so usually you listen to a recording of a man's voice and he says, say the word cat, say the word dog, say the word chair. And so it's important to consider your score on a test like that when we're thinking about, what are realistic expectations for situations where you still may have difficulty, even if you have the best, most appropriately fit hearing aids in the world. Because what can happen with hearing loss, hearing loss obviously affects the volume of sound and the volume that we need in order to hear speech. But, the processes that cause hearing loss can also impact how clear speech sounds. And so when scores on that test or, tests like that are, not very high, what that can tell me as an audiologist and what I like to talk about with patients is that even when speech is loud enough for your ears to hear it, it's not always going to sound clear. And so if you have some difficulty with that test, which is done in a really quiet room and the voice is nice and loud and the speaker is nice and clear, if even that is a situation where you have some people have a lot of difficulty, I'm not going to expect that hearing aids are going to fix all of your listening problems. They're going to help in a lot of situations and they're going to make things better, but we're still putting, a better signal into an ear that's damaged or not functioning the way we would expect. And so, that really is a challenge for many people. So I think that's something I would add to that as well.
I think the comment about processing, the older I get, the more difficulty I have. I know that I'm hearing somebody, but the processing, and usually with young people, they are able to speak so quickly. And they could be speaking in Greek to me, and I wouldn't have any more idea of what they were saying. So you can always tell when you're on the phone with somebody who you don't know, and they're speaking so rapidly. They finally say, I'm hearing you, but I'm not processing. If you slow down, I'll be able to comprehend much better what you're saying. So yeah, that's a whole topic, I think, in itself. Processing versus hearing. So anyway, yes, now we have Janet with a question and then our president. So Janet, what's your question?
I'd like to bring up the subject of telecoils, T-coils in hearing aids. There, in fact, an article appeared recently in some publication and online that people with hearing loss still can use and benefit from telecoils, but either somebody is falling down on the job because people who wear hearing aids, so many of them if you ask them, well, does your hearing aid have a telecoil? They will say, what's a telecoil? Can you comment on this? Both of you. Thank you.
Okay, which one would like to take this question first?
Again.
Okay, Peter, thank you.
Yeah, so, I think you're 100% right in that sense is, and I don't want to pin it on the hearing aid manufacturers, because it's not all pinned on them, but unfortunately, they're always trying to make hearing aids smaller. And one of the first pieces of technology to get cut when they shrink hearing aids down is the telecoil, which, doesn't make a heck of a lot of sense, because, that, I think, even though it's a relatively old technology, for some of the most challenging environments like church or the theater can make a huge impact, positive impact. We're trying to, or at least our state board is trying to sort of whip us into shape on that we have to do a telecoil, continuing education every couple of years. So, it's some of it's just trained habit. Rochester, we have the benefit of having so many hearing loops in the area that, maybe locally, at least, we like to think we're a little bit better about pushing telecoils, educating patients about telecoils, saying, oh, well, the hearing aid might be a tiny bit bigger with a telecoil, but the benefit that you're going to receive, will be significantly outweighed by that size difference. So I personally think we are getting better at it. Every manufacturer of hearing aids has very good hearing aids with telecoil, a telecoil built in. But I agree, we do have to get better at sort of making that a rule on every person that we see come in the door. That should be discussed.
Yes. Okay, Carly?
Sure. So what I would add to that is that, so I'm going to pin the blame on audiologists either way, because something else that we need to consider when we think about whether people, have telecoils in their hearing aids, but also whether people know that they have telecoils in their hearing aids, is, did people actually understand that they had a telecoil, understand what it was, and know how to use it? And so we know from research in audiology that when audiologists counsel patients remember 50%, about 50% of what the audiologist said. And of the 50% that they remember, they only remember 50% of that correctly. So I always think about, when I'm counseling, the fact that my patient is going to get about 25% of what I said correct. That's what they're going to leave remembering. And so when I earned my PhD, I wrote my dissertation looking at whether there was a better way that audiologists could teach people about their hearing aids and about how to use and care for their hearing aids. And what I found was that, if audiologists used a specific tool that basically forced them every time they saw the patient to ask the patient specific questions and to ask the patient to demonstrate that they could do specific tasks with their hearing aids, like putting it in, taking it out, changing the battery, cleaning it. If an audiologist did that every time they saw the patient for the first 4 weeks that the patient had the hearing aid, then the patient was able to maintain their skills. If the audiologist didn't ask those specific questions, if all they asked was, how are things going? Do you have any questions? That even in as little as 4 weeks after first getting the hearing aids, people forgot a lot of the things that they had known after the first appointment. And so I think when we think about telecoils, I often see people who, when I hook their hearing aids up to the computer and look and see what's going on in their hearing aid, I see that they have a telecoil program. And, I'll say, oh, do you use your telecoil? And they say, what's a telecoil? I don't know. I don't think my hearing aid has that. And I know their hearing aid has it. And I know that the audiologist who set them up with their hearing aid probably told them about it because they set up a program. But we as audiologists also need to work on how do we present information to patients and how do we counsel on a consistent basis to ensure that people actually know how to optimize the use of their devices to give them the most benefit in the most situations.
What an excellent comment. Wow, that was really, really good. Thank you so much for that. Okay, Mr. President, you have a question.
Yeah, by the way, Charlie, that was really good, what you just said. Yeah. I wish more people would do that on more things. Anyhow, I want to go back to the speed issue, the processing of the brain issue. Some of this is anecdotal, so take it for what it's worth. But as I get older, I notice that I'm more sensitive to that. Like TV news announcers, if they seem some of the young ones talk very fast, and I have trouble keeping up with them. I have to work to keep up with them. Now, many years ago at a PAC meeting, a professional advisory committee meeting, there was a researcher from Strong, a doctor who gave a presentation. And I remember that one of the things he was doing was measuring the speed of electrons going over the brain of a mouse. Now, I don't know how you do that, but apparently they, have the instruments to do that with. But they are finding that there's fluid in the brain that as you get older, it gets a little sicker and it slows down. And that seems to be the thing that causes this phenomena as we get older. And of course, I'm in my 80s now, so I'm feeling a lot of this stuff. Anyhow, so we all said, well, how do you solve this problem? He said, you're going to like this one. He said, 1 glass of red wine a day. Just one. Not 2, just 1. It'll help you a lot.
Oh, that's very, very good. I'm sure that's the most favorite answer we've had today.
So there's our contribution of unprofessional advice today.
I would like to call on Barb Rice because she has a friend who is going to be getting a hearing aid or has a hearing loss. And we cannot see your friend, Barb, but I know she's sitting right now. There she is. Oh, good. Great. And can you unmute yourself, Barb? Can you please unmute yourself and introduce your new friend to our group? You're still muted. There you go. Would you please introduce your friend to everybody?
Yeah, my friend is Regina Morricone, and she has been looking into getting new hearing aids. So I thought it would be very useful for her to take part in this meeting. And because I know I have been wearing hearing aids for many years, I still learn something from this group every time I come to your meetings.
Well, Regina, is it? Regina?
Yes. Yes.
Regina, welcome. We're so glad that you came, and we hope listening to Dr. Hart and Dr. Alecia will be helpful. Do you have any questions for the 2 audiologists?
No, I've learned a great deal so far, and now I know what questions to ask my audiologist when I see him in April.
You'll definitely ask about a telecoil, I hope, after hearing.
Never heard of it before, but now I know.
Oh, great. Okay. Oh, we're so glad you're here, and please continue to join us.
I'd love to.
Yes, thank you. And we have someone new, Michelle Frisbee. We have not met you before. And are you local? Are you from the Rochester area?
Hi, sorry, my lighting is not very good here. I know that's a taboo, bad thing, but there's bright sun behind me and I can't figure out how to fix it. But anyway, I am from the Fox Valley, Wisconsin chapter.
Oh my goodness. So you must know Julie Olson.
Oh, yes. Yeah, we talk almost every day, and I'm currently the treasurer of our chapter and a past president, and I'm also treasurer for our state organization now. So I know Julie reminded me that this Rochester chapter, I guess, is considered a sister chapter of Fox Valley. I don't know exactly what that means, but I guess we go back many years for this.
We do. We steal a lot of your good ideas.
Yeah,
like the Hope Session. You started the Hope Session. And that's where we picked up on that.
Yeah, that's wonderful. Yeah, I'm glad a lot of chapters are doing that today. So that's a great thing that is available to everybody. I do have, I'm glad you called on me. I was just gonna try to ask a couple of questions around technology. I actually am a bilateral cochlear implant wearer, but I did wear hearing aids for a number of years. And I guess I just chimed into this to see what was said about OTC and what's said about new technology, because I just recently got upgraded cochlear implants. And with that, I got a new iPhone, and they're now compatible with Bluetooth that I previously had with my prior implants. I had to use an accessory, a mini mic or a phone clip to hear, through videos or whatever, and love the built-in telecoil, whatever capability. But I'm having a love-hate relationship with this iPhone and the Bluetooth technology that is so automatic now that it's driving me insane. So I'm wondering if you have any comments on that, because when I talk to my local audiologist who now does both, we have one that does both hearing aids, and they're doing some cochlear implants, but they're getting new in the cochlear implant realm. So I feel like we're training them a bit more than they're helping us. So I'm wondering what you think about this automatic Bluetooth, because to just describe situations, it's great, but yet it's frustrating when it can't switch, or it does automatically switch when we don't want it to. So it automatically goes off in my head anytime there's a phone call. It has a hard time switching between Bluetooth when I go from my phone in the house versus I go into my car. And if I want to do a GPS route on my phone, it starts talking to me in my head, but then somebody calls in my car on Bluetooth and it's switching back and forth. So, and somebody else told me that hearing aid wearers have very similar experiences with Bluetooth. So I'm just curious if you have any tips or where you think that's headed in the future of Bluetooth technology.
Okay, we have about 3 minutes left. And
sorry.
If we have that's great. We adjourn promptly at 1 o'clock. So which of our dear audiologists would be willing to give this a try?
I can start. Yeah, so we do hear similar complaints often. Bluetooth is a great technology. It's also not the smartest technology or the most stable of technologies. And often it's and I actually run into it a little bit more frequently with iPhone users for some reason, but the iPhone is trying to sort of dictate where does it think that you want to hear whatever it may be, whether it's the phone or, Google Map directions. There's some hearing aids out that are, and I'm not, completely familiar with cochlear implants, but I know in terms of hearing aids, there's some hearing aids out that are made for iPhone. And those hearing aids at least give the patient a little bit more flexibility when they, go onto the back end of the phone. They can adjust some of the settings, whether they want to hear a phone, the phone call or not the phone call, but the the ringtone in their ears or text alerts in their ears, or if they just want phone calls and not like Google Maps in their ears. So some hearing aids I know have some capability to sort of tweak things a little bit, but other hearing aids that are viewed really just as, you know, the phone sees them as Bluetooth headsets, you know, it's a little bit more limited in terms of, you know, the user or the patient doesn't have a ton of control. There's a setting in the iPhone called audio routing. So if you go into the iPhone, just type in audio routing, you can sort of dictate what's the default. So you can switch it between the cochlear implants or the hearing aids, the phone, or speakerphone. So for example, if you get a phone call and you want it to default through the cochlear implants, you can set that. So every time you answer a call, it'll go through the implants. Or if you don't want it to default, you know, if you'd rather have it just default to your phone, you can also set that. And then you can manually select the hearing aids or the implants. But, you know, that's the main setting that I know of. If your cochlear implants aren't made for iPhone.
Wow, you do like technology, don't you?
Yeah.
You're good
To a
at that.
fault.
Oh, Dr. Carly, we have 30 seconds. Do you have any important comment that you would like to add to that?
I'll just second what Dr. Hart said. And Michelle, do you have brand cochlear implants?
Yes, I do.
Okay, so I do believe that you should be able to change those settings that Dr. Hart talked about. You know, I do believe that
I have been kind of experimenting with that a little bit. It's just hard. I would love if audiologists had like a mini apartment in their audiology offices, and you could mimic life, and you could try within your appointments to use the technology and get trained on some of this stuff. Because then, like a lot of people, I live alone, so I don't have somebody else to practice with on a daily basis.
Right, so that way.
So
yeah, I know I need to practice a bit more, so I will.
Okay, it is exactly 1 o'clock. And Barb, I will, before I just say, Barb, if you'd like to finish the meeting, I think our two audiologists were absolutely fantastic. You were both so knowledgeable. We could go on for another hour. So thank you, thank you, thank you. Many thanks. You were wonderful. And Barb, I'll turn it back over to you.
Okay, I just want to thank everyone who helped to facilitate this meeting, and especially the two audiologists. And I want to remind everybody to complete the evaluation forms, please, that are in your Zoom invitation, and send them to Carol Bradshaw. So thanks again, everyone, and we really had a great meeting, I think. So, and remember next month to come back, okay? For Dr. Porstensen. Thank you. Bye-bye.
Bye.
I'm going to stop recording.